panel discussions are innovative. It's a great benefit for anyone who takes the time to attend this meeting.
And there was a very practical handling of how to use imaging, how to make interpretation.
Also, it touches various topics, both on the coronary and structural side. Very insightful, exchanging scientific data and results of trials.
And several live cases have been performed to show complex, innovative procedures. Several workshops were from so much of intense academics that we've been having since morning. So we are ready to roll for the post-lunch session. And now we have a variety of presentations, and I'm going to put all the presentations in a single session. So let me invite my experts, Dr. Hani Reggie, Dr. Sasko Kadev, Dr. Praveer Agarwal, Dr. Sarita Rao, Milind Hote, Dr. George Joseph, Dr. Rahul Malhotra, Sophie, दोनों साइड उधर लगा दो. Dr. Rahul Malhotra, Dr. B.S. Vivek, Dr. Vivut Pratap Singh, George, come. Dr. Ashwini Yadav, Dr. Dhirendra Singhania, Dr. Fayaz Ahmed, Dr. Sajal Gupta, Dr. Vishal Rastogi, and Dr. Rustem Datov. Rustem, please join us over there. So we have some very interesting presentations, and we'll let everybody join in as they finish their lunch. And the first presentation is Dr. Bali here, H.K. Bali? Yeah, so we'll start with Dr. Bali's presentation first. He's got some soul-stirring presentation to open up our minds. Can we have AV team help him connect the laptop, please?
No flow during a left main ostial stenting. My patient is a 79-year-old physician, a leading physician in our area, with a known case of diabetes, hypertension, hypothyroidism, and bronchial asthma. He presented with recent onset angina, rest angina for the last few days. On examination, clinical examination was normal. EC showed a dynamic ST depression V3 to V6, and echo was normal. His investigations were normal, and he was because of unstable angina, acute coronary syndrome, he was taken for angiography. This is a left coronary angiogram, which shows a critical stenosis of the left main ostium and severe calcific disease in proximal and mid circumflex. And you can see there was a damping of the pressure during this time, and the lesion in the ostium of the left main looks to be ulcerated and probably thrombotic. These are the other views showing heavily calcified circumflex disease. The right coronary was also heavily diseased, starting from the ostium to ostium proximal and mid part, and distal RCA had critical stenosis. So with this, we were obviously dealing with the ostial left main and triple vessel disease, calcified disease. The left ventricle function was normal. He was offered a bypass surgery, but he refused, and he was very insistent that we do a multi-vessel PCI. We considered a protected angioplasty stenting, but because the left ventricle function was normal, we decided to go ahead and do a multi-vessel PCI. The procedure was done through the femoral route. It was loaded with clopidogrel and aspirin. Unfractionated heparin was given. We chose a 7 French JL4 guide. The plan was to do it image guided, wire both the LED and circumflex, balloon dilate with the NC balloon, and do a plaque modification of the LCX calcific lesion with a cutting balloon and IVL. Stent from the LCX to the left main covering the ostium with a provisional stenting, do a first part sizing to left main, rewire the LED, do a kissing balloon dilatation of LED LCX using an undersized balloon for LED, do a final part, and in case of suboptimal result, convert to either a culotte or a tap technique and finish with the second part and optimize under IVS guidance. So this is the procedure. We wired both the vessels with a normal BMW wire, and you see the mid LED, there is a concertina effect, and which we confirmed in multiple views. We did a balloon angioplasty with a 2.5 millimeter balloon of the ostium of the left main, and used the same balloon for doing angioplasty of the circumflex. Then we used a bigger balloon, and during the balloon dilatation of the left main, we had little slow flow, bradycardia, but it was transitory and it recovered. So we used a 3 millimeter balloon to do an ostial LED because we wanted to have a good result at the ostium of the left main. And after that, using the same balloon, we did a angioplasty of the circumflex also. But just after that, patient complained of severe discomfort, had bradycardia followed by sinus arrest. BP became unrecordable, and patient became extremely uncomfortable, and there was profuse sweating. So this is what we got on angiography. There was no flow in the LED and no flow in the circumflex. So what did happen here? Could it be a dissection? And if you look at the circumflex, there is some filling defect in the circumflex, but there is no clear-cut flap. And could it be a distal embolization from the thrombotic ostial left main lesion, or sometime it can happen that in left main angioplasty stenting, left LV EDP may rise significantly, leading to no flow. So there was very little time to react on this thing. What do we do under such circumstances? Do we stent from the circumflex to left main, which was the original thought process, or put in IABP? We didn't have an impella at that time in the lab. Do a stent to left main to LED to get the LED flowing first, or convert to two-stent strategy. We couldn't plan to do a circumflex angioplasty stenting because the plaque modification had not been done, and there was every chance that the stent in the circumflex would not expand well. So we decided that let's do a left main to LED angioplasty. So we choose a 18 millimeter, 3.5 millimeter onyx stent and stented from the left main covering the ostium onto the LED. And after that, there was a rhythm which came up. The pressures started picking up, but there was no flow into the distal LED and the circumflex still. So one of the options was, as normally we do, is stent the LED also and the circumflex as well. But as we learned in the morning during Dr. Antonio Colombo's lecture, diagnosis is solving the problem. So what we did is rewired the circumflex, and this is the multiple views to show no flow in the LED and the circumflex. So we took after rewiring, we put in a 2 millimeter balloon and did a dottering of the LED mid part and dottering of the circumflex. And after that, we were able to establish good flow into the LED and circumflex. Then we did a part with a 4.5 into 8 millimeter balloon and took a IVL to do plaque modification of the circumflex artery. After plaque modification, deployed this is a C2 IVL being used. And then we deployed a 3.5 into 34 millimeter stent in the circumflex at nominal pressure, and another 3.5 in 18 millimeter doing a tap procedure at 10 atmosphere. Then we did a kissing balloon angioplasty using 3.5 millimeter two balloons, and then we did a final part. Final part with a 4.5 into 8 millimeter balloon. Repeated an IVUS at this time, and IVUS showed good result in the mid LED, ostial LED, carina, and left main with good stent opposition and no distal dissection. So this is a final angiographic result showing good flow in both the circumflex and the LAD. So the next day, we took him for angioplasty stenting of the right coronary, which was again image guided. We used a cutting balloon to do plaque modification in this particular position. First an IVUS, then a cutting balloon, 3 into 15 millimeter balloon, Wolverine. And after that, confirming that we had achieved a good plaque modification, deployed 2 stents, one in the distal RCA and one in the proximal covering the ostium of the RCA. Optimized the result with an NCI balloon, and this is what we got finally. So this patient was discharged 2 days after the procedure, and he's doing very well at 6 months with no issues. The IVUS showed good result. So to conclude, I would say that left main PCI can be challenging at times. Image guidance obviously must be done always in such patients. No flow or a slow flow phenomena during an LM-plasty can be catastrophic. Recognition of cause of hemodynamic crash is solving half of the problem. Left main bifurcation of provisional stenting is treatment of choice in most of the patients. However, bailout 2-stent strategy may be required in suboptimal results or in compromised flow. In our case, thromboembolic occlusion of mid-LAD and circumflex from a friable left main ostium may have been the cause of hemodynamic collapse. Early recognition and prompt treatment saved the day. Thank you.
Thank you, Dr. Bali. Did you do IVUS before you started, right in the beginning?
No, we have planned, but the moment I would hook the left main, there would be severe drop in the pressure and hemodynamic compromise. So we do not have a pre-procedure IVUS. So we wanted to do an angioplasty first and then do IVUS before stenting it, but before that the patient had a hemodynamic collapse.
Now you said you're thinking about thromboembolic mid-occlusion as the reason for no flow. But we didn't see any really filling defects kind of thing. Was this more likely microemboli that clogged up the microcirculation rather than, big...
Yeah, Dr. Josh, that was the first thought process, that we have produced a microembolization distally. But we just did a dotting on the mid-LAD, did not use any, pharmacological agents to cause take care of the microembolization, and we were able to get a good result within seconds. So that would not happen in a patient who has got multiple microemboli going into the distal circulation and blocking the circulation. That would be very, very uncommon.
So, Dr. Bal, of course, we are talking about escalating level of risk, but he was a colleague, 77 years old, coming with an unstable situation, and the circle was codominant, and so just a couple of things. Number one, we might try to anticipate some problems and getting some sort of support for the left ventricle in case. And the second was the distal LAD had a very tight stenosis. So if you microembolize something, the LAD could be also occluded because there was this small lesion. So it was a very hectic situation in my view, but perhaps be careful a little bit in terms of...
Before starting the procedure, we did consider of doing a protected angioplasty using an impella, but the left ventricle function was normal. So that was something which, and taking cost factor into consideration, we decided. But now in retrospect, I believe that I think we could have put an IABP first before doing on with the procedure. As far as the second part is concerned, in the view which we've seen, there appears to be a tight lesion in the mid-LAD. But we withdrew the wire, and this was just a concertina effect. So we didn't have stenosis there. And throughout the procedure and subsequently at the end of the procedure also, there was no lesion there. So there was no lesion in the mid-LAD.
Your heparin and the ACT were good through the course?
Absolutely.
Yeah. What I usually do if it happens like any no reflow situation is thromboaspiration catheter quickly on both wires, one after another. Give, let's say, adenosine nitroglycerin if you have SNP, and balance it if necessary with metaraminol. But then you can also give injection through that lumen and understand what's happening, distal injections. If it's embolization or it's dissection or anything like that, yeah.
Yeah,
Very
I
quick.
think that is a very good suggestion, and that's what we normally do. That if we had not responded to doctoring, then we would have taken a microcatheter down the LED and injected through the lumen of that to see the distal circulation. That is what the next step obviously would have been.
What I mean is it's much better because the lumen is bigger and you have full control of the vessel because you do it on the wire, is aspiration catheter.
Aspiration, yeah.
Because with microcatheter you have to lose the wire. And the lumen is small, 0.14, 0.16 lumen is to give drugs or injection. While here you have full control, you just one vessel, another vessel, it's just my standard recipe. If it happens in the cath lab, sometimes no reflow suddenly.
Yeah, that's what we normally do, but here we didn't reach to that situation because before that, it happened over a period of few seconds, and we were able to establish blood flow by just doing a dotting.
Any other comments from the panel?
Great case. Usually, once the no flow starts, the timing is like few seconds only because the pressure drops like anything, and the dropping of pressure itself leads to slow flow. So you don't need microembolization or anything. Bradycardia and slow flow can happen just because of the no pressure at all. So maintaining pressure at times requires some of these procedures, they need immediate CPR backup till we are adding supports or doing the procedure.
Yeah, that's right. First and foremost, I believe that slow flow and no flow need to be prevented. That is the primary objective. And once we get it, then there are different methods to take care of it. We have pharmacological agents to take care of that, and I am very fond of using SNP, sodium nitroprusside, in such patients. Other prefer diltiazem, adenosine, and multiple other agents. So intracoronary epinephrine is another one. But raising the arterial pressure would be very, very good idea because that improves the coronary circulation, and we have multiple ways by which we can do it. And inotropes may be required, and sometimes you're right that CPR might be required. But it happened so rapidly, and we were able to revive the patient. So the point of showing this case is that this is probably not microembolization, which we normally get. If there was microembolization, all those things would need to be done. But here we were just by dottering, but in the mid-segment. So there are probably a thrombi. I haven't seen so many cases like that. But there is an ulcerated thrombotic plaque in the left main, and from there the emboli might have gone. So we are not dealing with a microcirculation blockage here. We are dealing with probably a larger thrombi in the mid-LAD and mid-circumflex part.
Okay, if there are no more questions, yeah, please.
Just a very quick, I mean, this was brilliantly managed, but just a very quick tip. If you get no reflow, and then you go in and you do another balloon inflation, and you take a picture, don't remove the balloon, because if you have the balloon in place and you have flow, and then you remove the balloon and the flow goes away, then you know, even without imaging, that you have a mechanical problem, not distal embolization. And then you can start focusing on which mechanical problem. Is it a large thrombus that you're pushing to the side, or is it a dissection flap? So I always inject with the balloon in place in the beginning, just manual, to see. And it's very frequent that you actually get flow, and you say, oh, good, you remove the balloon and there's no reflow again. And that is not usually distal embolization.
Thank you.
Thank you. Great case. And it's now my pleasure to invite Dr. Gary Rubin, who is the legend of carotid artery interventions, to talk on carotid access tips.
this the pointer? Thank you, everyone. I remain convinced that to prevent strokes by treating carotid disease, carotid stenosis, that interventional cardiologists are the operators that should be doing most of these procedures, not interventional neurologists, not vascular surgeons, not interventional radiologists, not neurosurgeons. But you have to know what you're doing, and for us interventional cardiologists, this is one of the simplest and most gratifying procedures that I did throughout my interventional cardiology career. So I'm going to give you some tips today on the first step. There are many elements to this procedure, and that's getting very safe carotid access. And we call this competent carotid stenting. And carotid access, of course, is the most critical first step in the procedure. But I would say before this even that patient selection, and these days we use CTA, MRA, and then clinical assessment. It's the most important thing in determining success, and what that means is a very quick, very fast, facile, and risk-free stroke intervention. I mentioned yesterday that we can do this procedure with under 0.5% peri-procedural stroke risk. But if you do not know what you're doing and don't use the right equipment, then you can have a stroke just trying to achieve access to the carotid artery. So these are some examples of cases that we should not be stenting. You see tortuosity in the great vessels, you see unfavorable arches. On the bottom panel here, you see this tortuosity. I saw a complication this morning related to a wire breaking, but really it was mostly about the fact that it was bad patient selection with tortuosity, which is the number one thing that we need to avoid. And it represents a very small minority of the patients we see for carotid stenting. So we avoid these patients, another example, then we can have a very fast and safe access approach. More examples. This is a CTA, and when you see this sort of raggedy arch with disease in the great vessels, you know that this is not a case for carotid stenting. We have to always focus as interventional cardiologists, and I've seen it here these last 2 days, on best patient care. And if it cannot be CAS, there are alternatives. There is still CEA for these patients. Some are more suitable. There is now transcarotid stenting, which is, in my view, should be reserved for patients with these bad arches and tortuous vessels. And even in patients that are at high risk for endarterectomy, there is always the alternative of medical management, even in symptomatic patients, and this has not been explored fully. If you feel you have to go in and do something about a high-grade lesion, and you cause a stroke for that patient, a life-threatening or life-disabling stroke, then that is on you, and that is bad clinical judgment. So let's get down to how to get very safe, quick carotid access without any risk of stroke. The first thing is you need to have the correct devices, and they really are 5 French neuroradiology catheters, and for reasons I'll explain, 125 centimeters when you're doing, going ahead to do a carotid stent procedure. Glide wires, either an 035 stiff or an 038. And these are angle-tip glide wires. They make all the difference. You have a backup supercore wire for a support wire, and usually you will get by with 190 centimeter, but sometimes a 300 centimeter wire. There are a variety of good 6 French sheaths. I use the Cook shuttle sheath, but the important thing is you do not use a sheath for the flutter valve. You must use the Touille-Bourse adapter, because you need to be able to reverse flow and have complete flushing to make sure there's no air or there's no thrombus or any other debris in these sheaths. So first, neurocatheters, and my first tip, and most important tip. On the upper right, you see a whole variety of neurocatheters, and it's important that we use these and not coronary diagnostic or guiding catheters. And the reason is that these are designed for very safe, easy, stroke-free access to the carotid vessels. And I recommend, and I'll show you how to use, the VTEC catheter made by Cook, and to acknowledge the incredible neuroradiologist who was my partner and colleague, Jerry VTEC. So what do we need? And I'm going to show you a very quick, very facile coaxial technique. You need a glide wire, you need a 5 French, 125 centimeter neurocatheter, and you need a 6 French sheath. Step 1, you take the sheath and you position it over a standard guide wire in the upper third of the descending aorta. You flush it. I administer heparin through the sheath, or now I use bivalirudin routinely. You then advance the 5 French neurocatheter, the VTEC catheter, over the 038 angle tipped glide wire. And remember I said not 35, 038. And then you very slowly advance the VTEC catheter up to the arch. And I'll show you this in the next slide. The tip of the VTEC catheter needs to be headed north and posteriorly. If you do that, as I'll show you, you easily engage first the left subclavian. You can either put the wire out to make sure you're in that vessel. The next vessel will usually be the left common carotid. Remember, sometimes there's a vertebral artery which connects directly to the arch. And then finally, the innominate artery. What you do is you retract the VTEC a little bit. You'll see it pop into these vessels and give you really excellent backup, so you can easily pass your glide wire into the common carotid. Now, there are other neurocatheters that you can easily engage with a type 1 arch. But with the VTEC catheter, you will always engage even in a type 2 or a type 3 arch. So first, you advance the VTEC catheter over the wire, and then take the wire back, and it takes this shape. You direct it cephalad and posteriorly, and you will always engage first the subclavian, then the left common carotid, then the innominate. And it's a one-step procedure. You're not rotating a catheter. I see this all the time with operators using a right coronary catheter. You're not rotating it around against the wall of the aortic arch, and that's what releases debris and causes strokes that the surgeons tell us about happens. It doesn't happen if you use this technique. And if you use this one step of having the catheter in this position and then advancing it very gently, very slowly, directed cephalad and posteriorly. The next step, you advance the glide wire while gently pulling back on the VTEC catheter, which gives you a lot more support, the way it's shaped, and you have enough support to then very easily advance the neuro VTEC catheter to a secure position in the carotid. Next step is remove the wire, back flush, as you do with every step in a carotid intervention. And you can do an imaging run and do a roadmap if you wish. And you do that where you can image the bifurcation with the origin of the external carotid artery easily seen. And that allows you to make your first roadmap. You replace the 038 angle tip glide wire, and you carefully torque it up and into the external carotid artery. You never go into the internal carotid or manipulate any wire other than your very fine 014 wires you use for the filter devices or for the stent delivery, but you otherwise never enter the ICA, where you again run the risk of embolization. Step 3. This is where the coaxial technique is so brilliant. Controlling the glide wire, and you advance the VTEC up into the external carotid artery. Now you have a rail, and you just simply slide your sheath slowly up cephalad to the desired position in the internal carotid artery. You stay well clear of the bifurcation, about 5 centimeters below the bifurcation. Not low in the common carotid artery. You want exquisite control of everything you're doing when you cross the lesion and place your filter device and then place your stent. So to have the sheath at a point just below the bifurcation, but not too close, is the technique of choice. You remove the glide wire and the VTEC catheter. You can then inject through your sheath to get a working view, which may be a lateral view now, or maybe either RAO or LAO, which shows the lesion for your crossing wire. And now you have safely arrived with one step, coaxial, safe, quick access to the carotid lesion. A couple of tips. If you need more support because you have a type 2 or a type 3 arch, while you're in the external carotid artery, remove the 038 glide wire and replace it with a supercore support wire. You need to be very careful that you are very delicate in your wire control in the distal branches of the external carotid artery, or you can produce a perforation. In type 1 arches, you can just use the glide wire and you can slip the whole thing up, and it takes about, on average, less than a minute. So, in summary, 3 important points. Carotid access can be fast, facile, and very safe. As with all elements of a carotid intervention, optimal patient selection is really the fundamental first process. And the correct neurocatheters, guide wires, and sheaths are really essential to this facile technique. Thank you for your attention.
Dr. Rubin, a few questions if you don't mind. Sure. You want to?
So, Dr. Rubin, what is your personal position on protection devices? Because in Europe, we have many European operators that I think are over-exaggerating with 100% proximal protection in all cases. On the other side, we have a high-volume operators, sometimes doing procedure without any distal protection. So what is your personal
Okay. That's a good question. We did not have protection devices, distal filters, when we started, and you saw the numbers yesterday, about 5 to 7% of peri-procedural strokes. Now there's, as I explained yesterday, there is distal filter protection. There is now, I think, the unique protection with micromesh stents. And then there is the MoMA balloon reversal of flow. They're really the three main ones. There's also the new Walrus balloon sheaths. I'm not so sure about those yet. We need more data on those. My approach is, until we have better data, with all of our stenting, we should use distal protection. When we have very complex, fresh, symptomatic lesions, proximal protection with the MoMA device is quick. It's easy for us. You have to use slightly bigger sheath, but that's not a big deal for interventional cardiologists. And so there's no question that either flow reversal or distal protection is helpful. And I think the best protection we get now going forward is this micromesh stent. Does that answer the question? Yeah.
One question from me, if you don't mind. You mentioned that you park the 038 glide wire in the external carotid artery usually. What do you do if there is disease in the common carotid just below the bifurcation, and if the external carotid is either stenotic or occluded?
Right. You can pass the glide wire and the VTEC catheter through the external carotid lesion, and I've never seen the complication I did in my career, close to 3,000 cases. If it's occluded, it's a different situation, and what we do is we get to just below the bifurcation, we bring the VTEC catheter up there, we put a little coil on the supracore wire, just over the back of your blade, and then you put the supracore wire up and just have it loop around below the bifurcation. It's plenty of support. Sometimes you don't even need to do that. Sometimes and often, if you use an 038 angle tip glide wire, you keep it away from the internal carotid, you'll find everything slides up very easily. Sometimes asking the patient to take a deep breath just opens everything up a little bit for you. That's another gentle tip. Yeah.
Thank you. Can I ask a question?
Yes. Yeah. Thank you very much, Dr. Rubin. My question is about, suppose you do get a neurological deficit on table. Do you deal with them yourself? Do you look at what is the level of knowledge that the person who's doing carotid stenting should have, at least about the cerebral anatomy, knowing the names of the arteries, identifying the ones which got blocked? And also the second part of the question, if you get a transient neurological deficit which goes away, like the patient throws up and is unwell, but then is okay, do you continue the procedure or do you do it on another day?
Yeah, these are sort of been eternally asked questions about carotid stenting. Now, if you think about it, if you're 1 in 100, 1 in 200, you're going to have a neurological event by using careful technique in well-selected patients, then I think it's a moot point that you need to know anything about what goes on in the brain. In the early days, we saw lots of embolic events, and we thought it was important to know what was going on. I think it behoves you anyway to know what's going on with the anatomy in the brain. We know about it in the heart. It's not that complicated, to tell you the truth, compared to the heart. So that's one thing. It's such a rare event. And there's another very important point. The way we perform carotid stenting now with the dedicated equipment we have, 99% of the time, when you have a patient with some neurological event, it may be they get a bit confused. Sometimes the nurse will notice they're not moving a hand, but usually it's not much. If you look, and I did this with hundreds, thousands of cases with the neuroradiologist, you don't see anything. They're very tiny showers of tiny emboli, and you're not going to do anything. So the answer to the question, do you need to know about neurorescue? Well, I think for the 1 in 200 cases, maybe, if that's your interest. I happen to think interventional cardiologists can also be on call to use stent retrievers for acute large vessel strokes in the brain. But it is not important. What's important is to learn the correct techniques so that you never have a stroke. And you certainly never have a big, large vessel embolic stroke. They come from atrial fibrillation, they come from clot forming sometimes in the bifurcation, but they almost never occur when a competent operator is performing carotid stenting.
Can I have a small question, please, Dr. Sir?
Yeah.
Can you comment about pre-dilatation or direct stenting? What do you prefer, pre-dilatation or direct stenting?
I'm sorry.
Pre-dilatation of the lesion, or would you just directly stent?
Well, that's a good question, and thank you for asking that. Let's think about it. We should only be in asymptomatic patients, which is a very large majority of the patients we see, we should only be treating high-grade stenoses, 70, 80% or more. And so you should very gently predilate those with a 3.5, 40 millimeter balloon, because then you can, after you pass the filter, then you predilate. And that's because when you put the bulky, it's a 10 millimeter stent is the one you should always be using. When you put that delivery system through the lesion, you have a much better chance of gently getting through the lesion without bumping any plaque off the lesion. So I believe predilatation is important. If you're obviously treating a symptomatic but 50, 60% stenosis, which is legitimate, then you may not need to predilate. And does that answer your question?
Yes, thank you.
Thank you.
One last question, Gary. Atul here in the audience. In the audience, yeah. So, what is your view about using guiding catheters to perform carotid stenting for difficult and tortuous anatomies?
I'm sorry, I missed the question too.
Guiding catheter versus long sheath for carotid interventions, which would you prefer? A guiding catheter, working through that, or working through a long sheath?
Guiding catheters were specifically designed for us to use for coronary interventions. They are bulky, they're not nearly as flexible. A dedicated 6 French sheath with a Touy-Bourse adapter is what we should be using. It is, once you've done enough, it becomes really obvious that guiding catheters are suboptimal. So, and the sheath is the way to go. You have more room, it's lower profile with a bigger lumen, it's more flexible, it follows your wires and catheters up far more easily, and it's designed for that type of peripheral intervention. Thank you for asking that.
Thank you, Dr. Rubin. It's a pleasure to listen to the pioneer of carotid intervention. We'll move to the next speaker, Dr. Bedi, who is a vascular surgeon and runs a very large vascular surgery program here in Delhi. And he'll be talking to us about endovascular management of massive pulmonary thromboembolism.
Thank you, Dr. George, for the kind introduction, and it's always a pleasure to be out here. I thank Dr. Atul Mathur again for conducting this wonderful meeting and making us a part, my team also is a part of this meeting, and also thank you so much. Well, when you look at the endovascular management of pulmonary thromboembolism and all, of course, earlier the options were basically conducting a surgical option, which was again associated with a high risk. Then the next step was using systemic thrombolysis, which was many a time suboptimal in these kind of patients, and the patient used to be pretty critical. With the availability of newer modalities which are available today, the AI-based penumbra lightning system and the NRE flow retriever and all, I think there has been a paradigm shift in terms of managing these kind of patients, critically balanced patients and all, with these options which are there. So just to describe what is a penumbra lightning CAT16 that we have been using quite regularly now for the last few years. In acute massive pulmonary embolism, subacute pulmonary embolism with right atrial dysfunction, fragile and elderly patients with PE unfit for thrombolysis, I think these are the specific indications where definitely one can use this system, which is basically a computer-aided mechanical aspiration powered by an engine. And intra-procedural, you have an audio-visual cues out there, and a dual pressure sensors for real-time monitoring, and a microprocessor with proprietary thrombus removing algorithm and an automatic valve control, whether the valve is closed or open, and a lightning on-off switch, so you can control whether if the catheter is stuck in a clot, whether the catheter is moving, aspirating or not, you come to know with those cues. And the goal of the thrombus, or goal of the treatment is to remove the thrombus, deliver a powerful aspiration to thrombus-filled vasculature, and the mechanism is to need to generate deep continuous vacuum power, reinforced catheter design for aspiration and clot engagement. For a long time we used to be using guiding catheters and all these things which were there, but they were never really optimum for removing these kind of clots. And when you look at this, this is what a small video of this system is, that as you keep on seeing, you see the visual cues also, you hear the audio and visual basically sound, you can see the thrombus basically going into this machine out there. It is designed to save a lot of blood loss which normally happens, especially the 2.0 version which is there, 18:1 fluid loss savings with lightning versus the dynamic tubing. And it allows the physician to focus on clot removal, not managing the flow at that time. There's a one-touch for maximum aspiration, a powerful deep vacuum which is there, and a minus 29 millimeters of mercury in which case. And like you see in the picture on the right, you can take out all these clots once you cleared aspirating all the system out there. And this is just to show you another visual out here, what you're doing in this case. Of course, this is more for DVT, but the same thing applies to pulmonary embolism also, where we go into the pulmonary arteries. And then I'll show a few cases after that. You go with a 16 French sheath out there, and then of course in this case it is showing going to the other side and aspirating the clot. So I'll just move it forward. And what it does is once you got it engaged inside the thrombus, you keep on, with a catheter, you keep on sucking it out. And this of course is a real case which was just done about last week. A young female presented with massive pulmonary embolism. She was admitted in one hospital out there, subjected to thrombolysis for 24 hours, no relief at all. She was in bad shape in the ICUs. And then she was shifted across to us, and where we used this penumbra CAT16 system. And as you can see in the left pulmonary artery was completely occluded. And this is the clot which tends to come out along with some bit of blood which is there. And in between, of course, you have to keep on cleaning it up with saline and all that. And as you can see now here, the clot is significantly cleared off. And this is what came out of this particular patient. 48 hours later, this patient was going home. Another patient, a 27-year-old male with extensive DVT, lower limb, as well as pulmonary embolism. And again, out here, the CT pulmonary showed a small partial hypoxense thrombus in the proximal left main pulmonary artery and a saddle thrombus at the main pulmonary artery, bifurcation extending into both the sides. And again, here we did a venography, and then once we went inside, we went across. As you can see, there is some thrombus out here. We went into the right pulmonary artery, gradually cleaned up, and then went into the left pulmonary artery, trying to clean up all the thrombus out here. And this is, of course, a rapid video which is there just to show what the aspiration does. And then we start getting blood flow into the left as well as the right side. And then you take a pulmonary angio, as you can see now, the thrombus is clear to a large extent. And most of the times, in fact, when these patients come with acute and chronic kind of pulmonary embolism, a lot of old clot and plaque material also tends to come out with these ones. So that is the major advantage, that even subacute clots which were earlier being subjected to open surgical procedure, you can clean out these clots, especially up to the segmental level, you can clean out most of these clots. Another 80 years old female, hypertensive, iliofemoral chronic DVT, presented with fever and dyspnea since 1 month. Again, she developed pulmonary embolism, she had high PA pressures, and again we performed, and you can see the thrombus out here, and again we did a mechanical suction using a special kind of catheter also that they have, along with that trying to clear out all this thrombus from the lower part. There was some bit of chronic thrombus also, which we tried to remove whatever we could, but to a large extent we were able to clear out these clots and all and get flow across into the both sides. Then again we come to the next system which is there, which has also come into the market recently in the last 1 year, which is the flow reverse system, that is the NRE system which is there, which is transforming the treatment of acute pulmonary embolism. Again, this is something which doesn't really require any kind of equipment for suction and all that sort of thing. It's got some specific aspiration catheters, the flow reverse system which is there, and catheters, and along with that you have something like a Amplatzer plug, basically something which looks like that for taking out the thrombus from the pulmonary artery out here. And here what we do out here is that when we take the catheter up out here, we aspirate, and this simple device to remove the large volumes of clot. There's no equipment really required, but the whole catheter system is quite expensive. It treats the patient in a single lesion in the lytic-free approach. Avoids consequent ICU stay and rapid relief. So this is just to show you, again, a small video out here. First, of course, you go with a catheter, with a wire and a catheter. Sorry, it's gone back to, yeah. Sorry, the video is not playing, but anyway. I think the video is not playing. So anyway, with this particular catheter, you keep on sucking out the clot from there. And once you've taken out, then after that, you use something like the retriever system, which is there, and keep on sucking out. And these are the kind of clots, basically, which come out from the pulmonary artery. So these systems are also pretty expensive. The only challenge which is there is that we need to, basically, they are very expensive. So you have to choose your patients and manage them accordingly. I think the new systems today are easy to use with minimum blood losses and therefore less hemodynamic shifts. There are no side effects compared to thrombolysis, where chances of bleeding are much more, especially when you use a high dosage of thrombolytic drug. The use of AI to decrease the bleeding, so quick recovery. And of course, patients don't really have those kind of fluid shifts are there, so therefore, patients are reasonably hemodynamically stable. And patients can be discharged on the first or second day after the procedure. And especially it is useful for patients who are contraindicated for any kind of thrombolysis. Thank you again for a patient listening. Thank you. I bring warm greetings from my team.
Dr. Bedi, couple of questions. Number one, clinically speaking, which patient should be referred for this mechanical procedure? And if you have a network of a referral hospital, they are sending patient to you. And the second is when to stop, when you have a full cleaning, and please.
A great question. I think one is, of course, the earlier the patients are managed, any patient who's to some extent having dyspnea on exertion, elevated PA pressures, symptomatic, very symptomatic and all, and involving the main system which is there, the main pulmonary artery as well as the left and right pulmonary arteries, or even unilateral also. I think those are the patients who do require these kind of treatment, especially young patients who are old, young patients who are going to be pretty active in life. You're going to treat them with this particular modality. We use them quite often now. The second thing is that you asked about when to stop. I think that's again a great question. Like I said, that in this case, what we look at is cleaning out the main pulmonary artery, the right and left. And as long as patient is stable, you can go across up to the segmental arteries, but you don't really have to keep on pushing it all the way down. So you just try to clean out and get good results out there instead of trying to get a perfect result. I think that's something which is very important. You should know when to stop also at the same time.
Some of the older systems, we used to see this problem of patient hypotensing.
Correct.
when you start doing this.
Yeah.
Do you get that with the newer ones?
Not really, Dr. George. Actually, with the NRE system, the Penumbra 1.0, the earlier catheter which used to come, that used to have some significant blood losses. So we had to be very careful looking at the head end all the time to see or have the anesthetist and replacing the fluids accordingly. But with the 2.0 system, as long as you're wedged into the thrombus and aspirating, and one thing that you got to do is you got to be very, very trigger happy, that you keep on listening to the audio cues also, as well as keep on looking at the machine also. If it's sucking blood, you immediately stop. The red button which is there is the one which should be always there in your hand. So it's like trying to avoid an accident. You see a car coming and stopping in front of you, just brake. So brake hard out there. So that's what you got to do, that not to try to keep on sucking because you're getting good flows out there and the making, and all those sounds you got to follow them. Because the earlier system, that was the major problem, that you were having a lot of blood loss. Even with the NRE flow retriever also, that is the advantage basically because it only sucks the clot only. It doesn't really suck blood as such. Yeah.
For penumbra aspiration, for how long you recommend it for a patient? Like MI, so golden times. So what's your recommendation?
Yeah, I think that's again a great question. Ideally, earlier the thrombus, the patient presents earlier, it's better. Up to 3 weeks is probably the ideal time which is there. But as I mentioned, with this particular system, you can even take out some old clots also. But you should try to take up these patients at the earliest rather than delaying, because as the clots become harder, it becomes more difficult to, aspirate or remove most of them in that case. So earlier the better.
Earlier, because after some time it get clot stuck, so we are not able to aspirate.
Yes, that's why I said I showed you those pictures also, that many a times you have a lot of grey thrombus also coming out, or some plaque material also which tends to come out, especially when you're using it in the lower limbs, especially patients who have acute and chronic kind of a DVT. There we remove much more of clots as compared to the pulmonary artery. We remove from the IVC as well as from the, sometimes we've even had to clean out filters basically which were deployed many years earlier. You have to clean out all this plaque material and clots from the filters also.
Is there any data to show superiority of the penumbra regarding to medical therapy?
Sorry?
Is there any data show?
Well, I think we should be able to get some data from India soon, although internationally there is data available right now showing that this is much more efficacious. But I think now we have quite a few cases under our belt, and probably we should be coming out with that very soon.
Thank you.
Yeah, Dr. Bedi, just one small question here on the left side of yours. Okay. Yeah, so do you think of using maybe cell saver devices if you're using, let's say, penumbra 1 device and there's expected lots of blood loss?
Yeah, so, but like I said, that in this particular case, you don't really need to use a cell saver. Cell saver is when there's a insensible loss happening all the time. Here, what is there is basically it's a controlled loss. So whatever you're doing, you're not going to basically keep on sucking when you're in the true lumen. So what we do is that whenever, sometimes what happens is the machine basically, it's got the color on top on the penumbra system, which is basically green. The moment it becomes red, that means it's now stuck in the clot. So you just pull back the catheter a little bit, and the moment you get that blood flow coming into the catheter, you stop immediately and so you don't have to lose too much of blood. The second thing is that many a time there's a thick hard clot which is there which tends to get collected, in which case then we pull out the catheter, clean it up again with saline, and then push it back again out there. So you try to prevent all those kind of blood losses at the same time.
Sir, especially with the previous catheters, when we are aspirating it, we used to remove the catheter. Sometimes the tip of the catheter gets collapsed in the initial penumbra systems.
Yeah.
And when we actually tried to do it with braided catheters, but even then we have to remove it and declog it.
Yeah.
So when you speak about this inaris, it's a bigger French.
Yeah.
And when you have to access into the segmental arteries, do you use wire every time to put the wire in and take it across?
Not really. Again, the first question which you mentioned was basically a penumbra Cat 8 catheter was actually, to my mind, it was a lousy catheter. We used it and we had bad experience with that, despite using a wire inside. The tip, as you mentioned out there, that used to get closed off and all that, especially with a high power suction and all. So it was not really that effective and all. So that's why, in fact, once this Cat 16 came in or Cat 12 also came in, we were quite happy with that. And again, with both these devices, the bulky devices, of course, they are all 16 French devices, but then, the veins are pretty large out here and they can accommodate very easily. Most of the times you can go up, but selectively when you have to go into the left pulmonary artery or the right pulmonary artery, you have to basically go along with the wire, and sometimes you have to, basically go with a catheter. The penumbra has got a special catheter also. It's a longish catheter. It's a 150 centimeter catheter. So it tends to take you across into the left or the right pulmonary arteries. You can go as distal as you want and then keep on pulling back also.
And do you routinely employ this flow trigger things with the inari, or you just only suck it?
We have been using, so far we have had experience only with the penumbra catheter, not had my experience with the inari right now, so that's why I didn't show a real case out there.
Thank you.
Sir, first of all, I'm witness to the impressive work that you're doing, sir. We work in the same setup. And the results of these ferocious looking clots that you just shown, what is there to prevent us from using this? Is it the cost as the first line treatment?
Yeah.
Or are there certain problems practically that you have faced in this?
I think it's the cost which is there. The cost of the catheter for penumbra as well as the inari catheter is almost 11 lakhs. So you have to manage, and probably in India, of course, we do tend to reuse these catheters. That's the only way you can make it, you can break even, because otherwise most of the patients will not be able to afford that catheter. It's an expensive technology.
Sir, one more question, sir. In your first case, that was done, penumbra was done after failed thrombolysis.
Sorry?
Your first case, penumbra was done
Yeah.
after failed thrombolysis.
Yeah.
So if a patient comes to your setup, no contraindication to thrombolysis, you offer thrombolysis first or penumbra first?
Again, a great question out here. I think whenever your main pulmonary arteries are packed up with thrombus, you want to stabilize this patient at the earliest. Thrombolysis is, again, you can give it over 2 hours and all that, but it's really not really going to make much of a difference in that way. I think looking at our clinical experience over the years, I think all of you would have experience with treating pulmonary embolism with thrombolysis. It doesn't really give you optimal results. It will probably give you suboptimal. Here what you're doing is you're trying to clean out the complete main pulmonary artery, the right pulmonary artery or the left one also, and you get immediate results out there. So that's the main part. Within the whole procedure takes about 30 to 45 minutes and you're done with that one. So it doesn't really take very long also at the same time.
Thank you, Doctor. There's one more question, please.
So, thank you. It was very educational. Is there, in the imaging, any criteria in the CT imaging which makes you prefer a technique over the other?
You mean to say the catheter
Yeah, I
that
mean,
we use?
I assume all those patients get pulmonary CT before.
Yeah. So always you look at the CT pulmonary angio, and then after that you take a call. If the thrombus is there in the main pulmonary artery as well as the major trunks out there, definitely I think these patients are the one who warrant. We never try to clean out arteries where you have subsegmental thrombus or even segmental thrombus, because these patients are relatively stable. They can be managed with anticoagulants and all. Whereas these patients specifically who are, unstable, many a time having severe dyspnea, exertion and all that, those are the patients who really benefit very well with this one. Like this patient, first patient which I described, this patient was admitted in ICU for about 3 days. She was kept in ICU and she was not improving. And a bad prognosis was offered by the treating physician out there at that time, till they got shifted, and next day this patient was walking along in the corridors of our recovery.
And for those subsegmental ones, do you ever use local delivery thrombolysis?
Yes, and those ones, if required, you can definitely use. We put in a catheter from the jugular and, give thrombolysis from there.
Sir, one quick question. If a patient is very unstable hemodynamically, would you still consider doing this, or would you think of...
I think with a good support and all from the critical care people and all, it really makes a lot of difference, because if you're able to clean out the clots in about 10 to 15 minutes, you can stabilize the patient as compared to subjecting them to anything alternative, because even thrombolysis doesn't really work that effectively and so fast.
Thank you, Bedi. You want one last?
Yeah, many patients of severe, large, massive pulmonary embolism, once you start taking the catheter and wire, patient arrest.
So the only thing is to do cardiac massage and try to dislodge the thrombus and
even
then try to take it out.
It's very difficult to revive. We have seen 3-4 patients and died on the table.
See, that is something you can't really predict and all that sort of thing, but that's why I said that expeditious treatment is of course the most important part out here.
Early recognition.
He's anyway going to die if you don't revive him and
Exactly.
try to take out the thrombus. So
Yeah,
it is
good
all
old
the more
days.
important that in such sick patients, we should use this because thrombolysis also takes time to act.
Yeah.
So this is the treatment of choice. It's available and cost effective for the patient.
Thank you.
Thank you, Dr. Bedi, for such a wonderful presentation, and a big hand for Dr. Bedi. And now we are moving on to Chirag. Chirag will present a very exciting case and how he managed it, and this is while he was doing a TAVR procedure, right? Can somebody connect his laptop, please?
Thank you, Dr. Mathur. Greeting to the distinguished panel. It's been an honor and pleasure to be here. So I'm going to show you a case of a balloon expandable valve embolization. So we have an 86-year-old male who was referred for worsening shortness of breath. He had mixed aortic valve disease, paradoxical low flow, low gradient severe aortic stenosis, along with moderate to severe aortic regurgitation. His other comorbidities include persistent AFib on Coumadin, prior Micra pacemaker, non-obstructive CAD, diabetes, advanced CKD, sleep apnea, and prior multiple cancer. So this is his transthoracic echo. You can see the aortic valve is calcified, and you can also appreciate significant aortic regurgitation. The aortic valve area was 0.9 with a mean gradient of 20 with a moderate to severe AR. On invasive hemodynamics, you can clearly see elevated left ventricular end diastolic pressure, widened aortic pulse pressure, and almost near equalization of LV and aortic end diastolic pressure, all signifying significant aortic regurgitation. Left heart cath showed moderate LAD stenosis. We had a heart team discussion, and I think everybody will agree, considering his advanced age, comorbidities, he was deemed to be a more suitable candidate for TAVR over surgical aortic valve replacement. On CT planning, you can see the perimeter derived diameter was about 24 millimeters. He had a very enlarged sinuses, good femoral access, valve area of about 450. So our valve of choice in this case was in balloon expandable valve with a Sapien 3 Ultra. It's a relatively older case, a few years old. We did not have the Resilia valve, and considering his coronary artery disease, we thought that a balloon expandable valve is a better option than a self-expanding valve. A 26 millimeter S3 Ultra is about 16% oversized, which is a good sizing, so we thought that will be great. So I want you to focus on this valve deployment. So here we are pacing at 180 beats per minute. We are slowly inflating and the valve embolizes. At this stage, you can notice the valve is right across the left main. So the valve is already embolized. We tried to advance it, could not do it. So at this stage, the first thing that you do is you need to get the valve away from the left main. Otherwise, the patient will immediately go into cardiac arrest. So this is where we are. The valve has embolized. It's in the ascending aorta. Most important thing in this situation is don't panic. When you can see, I have done all fluoroseals. So, we had a situation under control. The valve is not across the left main. There is no concern for coronary obstruction. You essentially have done a good BAV. So patient usually is hemodynamically stable. And most importantly, it's always important to maintain a wire position across the embolized valve, because then you have a lot of options. Next step is to reposition the valve. Here we have a valve balloon across the embolized valve. So we inflated the valve balloon. It's very important not to inflate it fully, just to inflate as to anchor the valve and then slowly drag the valve through the arch into the proximal descending aorta. Once you are in the proximal descending aorta, it is important to make sure you are distal to your left subclavian artery, because once you are cleared of the great vessels, I think there is no concern, and you can safely place the valve anywhere in the descending aorta away from any major branches. So here we brought the valve to the proximal descending aorta, and then you fully inflate the valve to make sure the valve is well opposed. So there are two specialty balloons that not many people know, because usually it is in the realm of interventional radiology or vascular guys. But if the Sapien balloon is not across the embolized valve and you have a difficulty in advancing your balloon across the valve, you should take your delivery catheter out. A nucleus balloon, in my opinion, is the best balloon because you can see it's an hourglass shaped. So one of the concern when you drag the embolized valve into your defending aorta is you may create aortic dissection from the edges of the valve. But because the balloon is designed in such a way that because of the shoulders, it will help to have your valve away from the wall. So when you drag it back, you will get a nice path without any risk of dissection. And you can get a balloon diameter from 18 millimeter to 30 millimeter. So it will almost cover most of the valves. The French size is 10 to 14. So obviously you have a tower sheath across, so that's not a concern. If you have a very large valve, I don't have experience with my valve, but my valve octacore comes in a very large sizes and other large valve. We have this Reliant balloon that I have to use only one time, and this balloon can go up to 46 millimeters. So if, let's say, your descending aorta has a larger diameter, or sometimes you may have to deploy the valve also in the ascending aorta, which is usually larger, this balloon can be very handy. It is dependent on how much pressure and volume you fill into the balloon. It requires a 12 French sheath. So these are the two balloons that can help you in this situation. So this is the second valve deployment, and as you can see, during the second valve deployment, the valve also was trying to embolize, but this time we were very careful. We had a very slow deployment. We were able to position the valve right across the annulus, and this time we went almost with 4 cc's, which was 22% oversize. We had no issues going through the embolized valve in the descending aorta, and one question arises, why did the valve embolize? Most likely the valve embolized because of lack of anchoring. You can clearly see here on fluoro there is almost no calcium. Here we have a mechanism of aortic regurgitation of a predominant mechanism of valve failure rather than aortic stenosis. This is the post-TAVI hemodynamics. We have a good 90-10 deployment, and the gradient was gone. The diastolic pressure also improved. Very important to take the arch aortogram because obviously you have to make sure you have not created any dissection. Ideally, you should do a DFA shot. Here we did a regular shot, but that is something to keep in mind. And you should also pay attention to your embolized valve. Now you have a time, you can review your CT, you can make sure what's the diameter of your defending aorta. Here we had a diameter of about 24 millimeters, so we made sure that our valve is well expanded in the descending aorta. Also very important to get a CT in this situation. A small dissection may get missed, but you want to make sure everything is okay. So we did a tower CT. There is no aortic dissection. There was the embolized valve was away from major vascular structure. The patient is doing well at 3 years, so he has no limitation in performing routine activities. So if you're wondering what is going on, how is he doing? So the mid-LAD stenosis has progressed now to severe LAD stenosis. So this is a 6 months old angiogram. We brought him back for a PCI, so we were able to do a rota and a good result of the mid-LAD. And here you can see the embolized valve nicely in the defending aorta without any further mobilization. So this is some sort of algorithm. I reviewed all the literature. Whenever I have a complication, that is something I tend to do. I go back to the literature, see what else is published. I learn from other people's mistakes. I think that's a good way to learn and improve. So this is kind of an algorithm that I have made for balloon expandable valve embolization. Again, self-expanding valve embolization is a completely different animal, should be managed in a completely different way. But if your balloon expandable valve is embolized, if it embolized retrograde, that means into the aorta, then there are two options. Whether it is just supraannular, then if it is across the coronaries, your first step should be to reposition the valve, preferably using a distally inflated balloon or a snare. If you're unsuccessful, obviously the patient will be very sick by the time and you have to put them on ECMO and emergent surgery. But if the valve is in the ascending aorta, it is usually free floating in the ascending aorta. It's very important to have the wire across. If you don't have the wire and you are lucky that the embolized valve is properly oriented, you have time, you can gain access through the valve, you can rewire it, and then you can use your steps. But I have seen a case where a balloon expandable valve embolized into the ascending aorta, the operator lost the wire access, the valve flipped, loss of circulation, cardiac arrest, CPR. We were able to put the impella across the valve, and with the CPR, the patient went to OR. Fortunately, the patient survived, but I cannot say they will survive all the time. So very important to make sure the valve does not flip. If the valve embolizes antegrade, we had a case in which the valve embolizes into LVOT. However, anterior mitral valve leaflet was just spinning it there. There is an option that you can save the situation using a valve-in-valve just to tuck the valve there. But if it is free floating into the left ventricle, your only option is ECMO and emergent surgery. Thank you.
What is your thought on snaring the valve? Is it? I think the challenge is to grab some free edges in the balloon expandable.
For balloon expandable valve, you know, for evolute or self-expandable, we have these tabs that you can snare, and you should snare when self-expanding valve embolizes. But balloon expandable valve, there is no way to have the snare catch on to the valve. So the balloon is the best way. You can either go balloon distally and try to drag it, or you can balloon across the valve, inflate it, and then slowly pull the valve back.
Any comments over there? Rahul or Gulio?
No, one comment about the cause of this embolization. Also in the second attempt, you showed that the pacing was not fully stable, and there was so the pacing was losing the capture, and that is becoming extremely important, because if you have effective contraction in 1-2 beats, that could be exactly the cause for moving the valve. So you are so demanding in terms of accurate pacing that you needed to verify up front.
No, that's a great point. And, you know, the patient had a Micra pacemaker. This is an old, so I wonder if there is something to do with it. I mean, again, we interrogated the pacemaker, it was fine, and our practice is, even if you have a dual lead pacemaker or lead left pacemaker, we still do a TVP. We have now moved away to the wire pacing, so now we pace to the Safari wire. I think it is more predictable, so we have moved on to that practice, but you're absolutely right, TVP can dislodge. In this case, you know, sometimes it's chicken or the egg, because, you know, once the valve embolizes, because of lack of anchoring, your wire moves, you get an extra PVC, and then you scratch your head, whether it is the loss of capture or whether something, what came first. But obviously you have to make sure that your pacemaker is very good.
Any questions?
So Chirag, wonderful cases. So I have also encountered in two of these similar situations. So when we are pulling out the expanded tower ball, we need to make sure that we should not dissect. That's a first priority. Many times, because the aortic arch is small, or if there is any tortuosity in the aortic arch, so the learning point is not to force too much, because otherwise we might be dissecting. So it's better, if we are not able to pull it out, it's better to call the surgeon, get done the surgery. That would be better. Many times we have a wire access, we have a balloon inside, we have a embolized wall, but many times even after giving a too much force, we are not able to pull it out across the aortic arch, and that, if we are giving too much force, then it might be a catastrophe. So
no, absolutely, that's a great point, and that's why in my opinion the nucleus balloon, you know, we did not have at that time in the lab, now I have it. It's a great balloon, it's an hourglass balloon. It will give you this nice transition point that you will be able to pull it back. But yeah, you know, your point is well taken, and some people also have deployed the valve at the arch, in between your brachiocephalic and your left carotid, but you know, like desperate times needs desperate measures.
Thank you very much, Chirag. And before we close this session, I will take this opportunity now first to thank my team, which has helped bring together these 2 days of deliberations. They have tried their level best to see that your travel and your stay and your participation could be comfortable. So first of all, I would like to mention few names who have worked very hard over the last few months. And one of them is Priya Babbar. Then my team, Vibhuti Sharma and Reena Koirala. And my team of clinicians, Ashish Jaikishan, Vibhut Pratap Singh, Bhavuk, Bhavna, Atul Kaushik, Amirul. So they've all been working very quietly, sending me messages as to who's arrived, who's not reached, and we are trying to coordinate all these sessions. So a big thank you to all of you. And of course, all this has happened because the industry supports us. And we are very grateful for them that they have these educational grants for us to support this event. So thank you very much, and I look forward to meeting all of you again next year in the first weekend of August. And please have a safe journey back. Thanks a lot. Bye-bye.